Fluids and electrolytes. The exemplars in this module are dehydration and fluid volume overload, with interrelated concepts that include acid-base balance, hormonal regulation, nutrition, elimination, perfusion, gas exchange, cognition, and mobility. Fluid balance is defined as the regulation of body fluids, fluid osmolality, and electrolytes by processes such as filtration, diffusion, and osmosis. The process of regulating the extracellular fluid volume, or EFC, the body fluid osmolality, and plasma concentrations of electrolytes is another definition. This fluid is basically water, but it does contain substances that are dissolved and suspended in it. So some of the characteristics we are going to look at will be the volume and its degree of concentration, and we call that degree of concentration osmolality. Electrolytes are substances that are charged particles or ions whenever they're placed in water. And the electrolytes that we'll be looking at are sodium, potassium, calcium, and magnesium. All body fluids contain electrolytes, but the concentrations are going to be different depending on what area of the body we're looking at. So, a normal presentation, we have an optimal balance of fluids and electrolytes. Our intake is roughly going to equal the output, and our electrolyte levels should be within normal limits. So the physiological balance of fluids and electrolytes are going to be accomplished through three processes. The first process is intake and absorption, where we have the addition of fluids and electrolytes to the body, or intake, and their movement into the blood, which is absorption. The most common route of fluid and electrolyte intake will be oral, but it can also include intravenous, insertion into the rectum, introduction through a nasogastric tube or other tube in the gastrointestinal tract, installation into body cavities, and infusion into subcutaneous tissues or bone marrow. It's going to be influenced by habit and thirst, increased osmolality of body fluids, dry oral mucous membranes, angiotensin II and angiotensin III, and the arterial baroreceptor stimulation with severe hypovolemia can also trigger thirst in the body. The next process is distribution, which is the process of moving fluid and electrolytes between those various body fluid compartments. The compartments are going to include inside the cell, which is intracellular, and outside the cell, which is extracellular. Now, the extracellular compartment will include fluid between the cells, which is interstitial, and fluid inside the blood vessels, which is intravascular. And then the third process is output. Output is the removal of fluid and electrolytes from the body through urine and feces, and minimal output through feces unless the client has diarrhea, through the skin or diaphoresis, and the lungs through water vapor. Now we have what we call insensible water loss. Insensible water loss is basically an unmeasurable fluid loss. And this can be lost through the GI tract, so we normally will lose some fluid in the gastrointestinal system that's immeasurable, the lungs through the water vapor, and again, the skin through diaphoresis. Aldosterone and the antidiuretic hormone, or ADH, also help control output by triggering the body to hold on to or excrete fluids. Fluid balance is going to be determined by the amount of fluid taken in. It must roughly equal the amount of fluid that we lose, and this is going to be approximately 2,200 to 2,700 mLs per day. Almost all of the major organs are going to work together to help maintain a proper fluid balance. But the key organs that help regulate output include the kidneys, the skin, the lungs, and the intestines. And then, of course, the output should be approximately the same as the input, so 2,200 to 2,700 mLs per day. Now, alterations in fluid and electrolyte imbalance can be due to too little extracellular volume, and that can be caused by a normal output, but a deficient intake of sodium and water, such as a lack of access to sodium and water, or increased output not balanced by increased intake of sodium and water, such as vomiting, acute and chronic diarrhea, a draining gastrointestinal fistula or gastric suction, or gastric decompression, hemorrhage or burns, overuse of diuretics, or a lack of aldosterone. And too little extracellular volume can also be due to a rapid fluid shift for the extracellular volume into a third space, such as acute intestinal obstruction or a rapidly developing ascites. Another alteration is extracellular volume excess due to two things: output less than excessive or too rapid intake of sodium and water, such as excessive IV infusion of a sodium-containing isotonic solution, or a high intake of salty foods and water, and now we have retention. Or it could be caused by decreased output that's not balanced by decreased intake of sodium and water, such as oliguria. Remember, that's low urine output, aldosterone excess, or high levels of corticosteroids. Another abnormality can be hypernatremia, due to a normal output but a deficient intake of water. For example, maybe there's no access to water, or there's an inability to respond to thirst. Tube feedings without additional intake intake. Or it could be caused by increased output that's not balanced by increased water intake, such as vomiting or diarrhea with sodium replacement but not water replacement, or diabetes insipidus. Hyponatremia is another alteration that could be due to output that's less than excessive or rapid intake of water, such as an excessive rate or amount of D5W IV, a rapid oral intake of massive amounts of water, overuse of tap water enemas, or massive water replacement without sodium. Or it could also be caused by decreased output that's not balanced by a decreased intake of water, such as excessive antidiuretic hormone. Excuse me. Complications of imbalances can include impaired perfusion and oxygenation. With the deficit, we have decreased arterial blood pressure, and this could also lead to hypovolemic shock. With an excess, we have an increased distance between cells and capillaries that can actually impair oxygen transfer in the lungs. Excuse me. It can also impair the gas exchange in the lungs. With an electrolyte imbalance, especially potassium, magnesium, and calcium, we can have cardiac dysrhythmias. Another complication would be impaired cerebral function. This can occur with a fluid volume deficit or excess related to shriveling or swelling of the brain cells, especially associated with high or low levels of sodium. And impaired neuromuscular function, again due to imbalances of potassium, magnesium, and calcium. All three of those can impair neuromuscular function. As we look at the lifespan considerations, infants consist of about 70 to 80% water. Their kidneys are immature, so they are less able to conserve water. They have a more rapid respiration, and their body surface area compared to their body mass is greater than adults. All of this leads to a higher fluid exchange ratio than any other age group. With the older adult, they're only about 50% water. They do have a decreased thirst sensation, and they have reduced body water related to lower muscle mass and a greater percentage of fatty tissue. They also have decreased renal reserves due to a decreased number of nephrons. Risk factors for these alterations can include acute illness such as vomiting and diarrhea, age, the environment, gastrointestinal output, chronic diseases, major surgery, or traumas. Now, fluid movement is accomplished through three different processes. First of all, we have osmosis, which is the movement of water across a cell membrane from a less concentrated solution to a more concentrated solution. Basically, it is going to help distribute water between extracellular compartments and the cells. Diffusion, we have solutes that move from a solution of higher concentration to a solution of lower concentration. And then filtration. This distributes fluids between vascular and interstitial compartments, such as the kidneys filtering blood and elimination of wastes in urine. So let's look at our electrolytes. Sodium is really important in maintaining normal nerve and muscle activity, regulating osmotic pressure, and preserving acid-base balance, while the main role is going to be to regulate and distribute fluid in the body. So the most important thing about sodium is water follows sodium. If we have high levels of sodium, we usually have higher levels of water. Excuse me. It's also the major ion in the extracellular area. The normal levels are 135 to 145. With hyponatremia or low levels, it can be caused by profuse diaphoresis, diuresis, a loss of gastrointestinal secretions from suctioning or drains, and Addison's disease, which is a metabolic disease. The findings with hyponatremia: mental confusion, muscular weakness, anorexia or a lack of appetite, elevated body temperature, tachycardia, and seizures. We're going to treat this by encouraging the client to take in foods or fluids that are high in sodium. Maybe administer sodium chloride intravenously, or do fluid restrictions. And we do the fluid restriction to help concentrate the body fluids. It'll help concentrate that sodium and elevate the levels. And seizure precautions. With hypernatremia, we're going to look at the causes as being diarrhea, excessive salt intake, maybe a high fever, or we've lost too much water, or we're not taking in enough water. These clients are going to be very thirsty. Their mucous membranes are going to be very dry and sticky, especially at the gum-cheek juncture. And they're also going to have decreased urine output. Again, water follows sodium. If we have high levels of sodium in the blood, it's going to help keep water in the body. And fever may also be seen with hypernatremia. We're going to treat it by increasing water intake. We may give hypotonic IV solutions. We need to do our intake and output, assess the vital signs, and institute some dietary restrictions or supplements. We'll talk about this a little bit more later, but as far as nutrition, we know there's high levels of sodium in condiments, in the majority of our processed foods, and our processed meats or preserved meats, most of our canned foods. So it's important for us as nurses to teach the clients to read labels. If it states less than 5% on the daily value percentage, then that is actually considered low sodium. So we encourage these clients to use herbs or other garnishes to season their food to help decrease their sodium intake. They can also open a can of canned vegetables and rinse it off, and that will help remove some of that sodium. And a mnemonic to just help you remember some of this material. With potassium imbalance, its function is to help maintain normal nerve and muscle activity. It has to be maintained for neuromuscular responses to stimuli, and it is vital for cardiac, skeletal, and smooth muscle activity. What is going to be most important for you to remember about potassium, it's not the only thing, but most important thing, is if it is too high or too low, we could actually have potentially lethal cardiac arrhythmias. In other words, it can kill you. This is the ion that is going to be most prevalent in the intracellular compartments. Normal levels are 3.5 to 5.5. Hypokalemia can be caused by potassium-wasting diuretics such as furosemide or spironolactone. The GI tract fluid loss from suctioning, drains, or vomiting. The use of corticosteroids, IV insulin, and glucose. Insulin is actually an antidote for high levels of potassium, so naturally it's going to help lower potassium levels. These clients may exhibit fatigue, weakness, nausea, Again, those cardiac dysrhythmias, and paresthesias. Paresthesias are abnormal sensations in the extremities, such as numbness or tingling. We're going to treat it by changing them to potassium-sparing diuretics. Encourage them to eat foods that are high in potassium. Give oral supplements or replace potassium IV. We do need to understand that potassium should never be administered by an IV push method. We can give it IV piggyback, but never IV push. However, IV infusion of potassium is fine. So we can mix it with other solutions and administer it slowly that way. And if IV potassium burns during administration, we either need to slow down the rate or dilute it further. With hyperkalemia, this can be caused by renal failure. Our kidneys excrete potassium, and if our kidneys are not working, we're not getting rid of potassium, so our potassium levels increase. Maybe we are taking too many potassium-sparing diuretics, too many supplements. Potassium is really high in diet sodas. They have to get that flavor back somewhere, and potassium's one way of doing that. Crushing injuries is another cause. Addison's disease or parenteral potassium. These clients may have diarrhea, nausea, muscle weakness, and once again, those cardiac dysrhythmias. We're going to treat it by decreasing their potassium intake, administering insulin and glucose, maybe K-exolate, also known as sodium polystyrene. This is a medication that we give to our clients, especially in renal failure, because they're not able to excrete potassium. And sodium polystyrene, or K-exolate, is going to work in the bowel by exchanging sodium ions with potassium ions. So now we can excrete the potassium in the feces. So the big caveat there is we have to make sure we have good bowel function. We may also do peritoneal dialysis to help lower the potassium levels, or hemodialysis. As far as nurses, we need to make sure that we're administering medications as needed. Do dietary teaching. We know that potassium is easily obtained through a normal diet, but since it isn't retained, it has to be continually replaced. So clients need to be aware of what foods may be high in potassium. And again, we'll go over this again in a little bit, but some of those foods will include vegetables, dried peas and beans, bananas, oranges, and potatoes. There's some mnemonics here for you. Calcium. Calcium is involved in blood clotting, the transmission of nerve impulses, and it's regulated by the parathyroid gland. Excuse me. The parathyroid is located behind the thyroid in the neck. Calcium absorption will be dependent on having an adequate availability of vitamin D. If we don't have enough vitamin D in our body, then our bodies are not going to absorb calcium as well as it should. So with hypocalcemia, the causes of hypocalcemia, we have that vitamin D deficiency. We may have hypoparathyroidism, burns, pancreatitis, corticosteroids, blood administration. We have an intestinal malabsorption problem. It can often be the result of damage or inadvertent removal of the parathyroid during a thyroidectomy. These clients are going to have tingling, circummoral paresthesia, so numbness or tingling around the mouth, muscle cramps, the positive caustic sign. This is where you tap the nerve in front of the ear on the cheek, and it causes muscle twitching. The Trousseau sign, bleeding, or tetany. We're going to treat it by giving oral calcium and vitamin D, maybe even IV calcium. If symptoms are noted, then we do perform the caustics or Trousseau sign. And if those signs are positive, we should always confirm the calcium level with a lab level and then immediately notify the healthcare provider because this can be an emergent situation. With hypercalcemia, this could be caused by a parathyroid tumor, multiple fractures, Paget's disease, prolonged immobilization, chemotherapy agents, and multiple myeloma. Now think about this for a second. The most important thing to remember with hypocalcemia is this is going to affect the muscles. It affects the muscles' contractility. It increases that contractility. So we can have the twitching or the intermittent muscle contractions, or tetany, where we have that steady, prolonged muscle contraction. But this is the level in the blood. So now if we have hypercalcemia, we have a high level of calcium in the blood. Where's calcium coming from? Well, it usually comes from the bone. So if we have high levels in the blood, that means now we have low levels in the bone. So with hypercalcemia, then it's going to start affecting the bone. So we have deep bone pain, anorexia, or that loss of appetite, constipation, polyuria, pathologic fractures. Remember, this is a fracture without injury. So the bone becomes weak and brittle because all of the calcium has been pulled out of the bone into the bloodstream. Another problem with hypercalcemia is it is the main component in most kidney or urinary stones. So the client is at a high risk for kidney or urinary stones. We're going to identify the cause of hypercalcemia. Maybe administer IV sodium chloride, furosemide to help pull some of that calcium out, corticosteroids, or plicamycin. We also need to monitor for complications, provide diet teaching about calcium, and initiate fall safety. Magnesium. Magnesium is mostly going to be involved in our muscle reactivity, or now I can't even think of the word, it'll come to me. So its main function is the transmission of nerve impulses, the activation of enzyme systems that includes the function of the B vitamins. We do have to have a healthy intestinal epithelium in the terminal portion of the ileum for magnesium absorption. With hypomagnesemia, refluxes, that's what I'm trying to think of. Think of magnesium being involved with our refluxes. It's also going to help slow down the CNS, and we'll talk about that as we go along here. Okay, so most common cause in the United States is alcoholism. Additional causes include diabetic ketoacidosis, renal disease, burns, malnutrition, intestinal malabsorption, diureses, and prolonged gastric suction. So these clients may have tachycardia. They may have paresthesias, so that abnormal sensation in the extremities, such as numbness or tingling. Neuromuscular irritability, so they're going to have hyperreflexes. They're going to be very sensitive to stimulation and could potentially have seizures. Their blood pressure is going to be high, and they can have mental changes. So we're going to give oral or IV magnesium or diet supplements. Now, giving it IV, this can be pretty rough. We have to monitor these clients very closely. So we're monitoring for potential toxicity or hypermagnesemia. Causes of hypermagnesemia would be renal failure, Addison's disease, excessive antacid or laxative use, or hyperparathyroidism. So these clients, and these are what you would monitor for if you're administering IV magnesium. You're monitoring for flushing, hypotension, lethargy, bradycardia. We can also have respiratory depression, muscle weakness, and or coma. That would be a sign that we're giving too much magnesium and we need to stop the infusion. We're going to decrease the magnesium, whether it's oral or IV. These clients, because of the respiratory depression, may require mechanical ventilation. We're going to treat any potential arrhythmias, treat the blood pressure. We're going to monitor the respiratory system, monitor for neuromuscular irritability, and monitor all of their vital signs. So once again, with hypomagnesemia, we have to decrease stimulation to help prevent seizures, dark room, no visitors, minimal visitors, no television. They just have to lie there quietly. We're going to give them magnesium. Every hour, we're going to be checking their reflexes to determine if they're hyperactive or if they're slow. We want them to be within a normal range. We're going to be monitoring their blood pressure for flushing, for that lethargy, bradycardia, and respiratory status. Excuse me. So focused nursing assessments are going to be looking at body weight changes, especially with fluid disturbances. Episodes of nausea, vomiting, diarrhea. We need to look at those vital signs. With hypovolemia or dehydration, blood pressure will be low, or orthostatic hypotension. With fluid volume overload, blood pressure will be high. With low fluid volume, the deficit, our heart rate is going to be fast because we're trying to make up for the lack of fluid. We're trying to perfuse the body. So the heart will beat faster to try and get that perfusion going. But the pulse is going to be weak and thready. With fluid overload, that pulse is going to be very bounding, so really strong, stronger than usual. We're looking at skin and mucous membranes, the fullness of the neck veins, and the capillary refill. We're auscultating lungs and looking at urine output. We're going to do a thorough history, looking at the client's age, what type of environment are they normally in or frequently in? What is their dietary and fluid intake? What is their lifestyle? And what medications do they take? Have they had recent surgeries? What is their normal gastrointestinal output? What is their normal urine output? Do they have any acute or chronic illnesses or trauma? We need to look at lab values, especially those electrolyte levels. Hemoglobin, hematocrit, the blood urea nitrogen or BUN, and creatinine are going to be the two renal tests that are going to help identify renal function. Creatinine is more sensitive than the BUN, so it's actually going to be a little more accurate. We can also do the serum osmolality or a urinalysis. Possible hypotheses or client problems associated with fluid imbalances or electrolyte imbalances include deficient fluid volume or dehydration, excess fluid volume or fluid overload, risk for electrolyte imbalance, which could be with either fluid imbalance, acute confusion, seen with dehydration and some of our electrolyte imbalances, risk for injury, that dehydration. Remember, it's going to cause hypotension. So these clients may have that orthostatic symptoms, such as dizziness and lightheadedness, which increases their risk for falls, and deficient knowledge regarding disease management. So another mnemonic for creatinine and BUN. So what are we going to do? Well, here's some generalized interventions. As far as independent interventions, the priority is going to be to maintain the client's safety and comfort. Now, common interventions both for deficit and excess of fluid would be daily weight. This becomes even more important if we have a severe deficit or severe excess, and doing intakes and outputs. The daily weight can actually be very accurate in helping to identify fluid volume status without looking at the blood work. Collaborative interventions will include administration of IV fluids, the encouraging or restricting of oral fluid intake, doing accurate intake and output, and possibly doing hourly urine outputs. Administration of medications, such as diuretics, per the provider's order. With health promotion, primary prevention, we educate the client on drinking adequate amounts of fluid, and they need 8 to 12 glasses of water a day. And when we're talking a glass, a glass would be 8 ounces or a cup. The older adults may not feel really thirsty, or they may want to limit their fluid intake to help prevent urinary incontinence. So it's really important to educate them about the importance of drinking that adequate fluid volume to help prevent dehydration or help prevent UTIs. We should educate all adults about a well-balanced diet to help promote electrolyte balances and encourage foods that contain a high concentration of essential vitamins, minerals, and electrolytes. With secondary prevention, getting those annual exams, and that will probably include an annual CBC or complete blood count and periodic electrolyte levels. So here's our diet and some of the foods that we can find high levels of these foods or electrolytes in. So again, foods that are high in sodium include those processed foods, those canned foods. Now, canned fruit has minimal sodium in it. We're looking more at the vegetables. Those smoked or preserved meats, condiments, so like ketchup and mustard and soy sauce. Those condiments are really high in sodium. Again, we can rinse foods off once we open up a can to help remove extra sodium, but it's not necessarily going to remove all of it. Foods that are high in potassium include a lot of our fruits, avocados, spinach, potatoes and sweet potatoes, acorn squash, salmon, and broccoli. Now, if you're a fruit lover and you don't need all that potassium, consider berries, cherries, apples, grapes, and peaches. They're going to be lower in potassium. Foods that are high in calcium include dairy, dark green leafy vegetables, and salmon. Foods that are high in magnesium include seeds, nuts, spinach, avocados, figs, bananas, berries, and kiwi. And if we want to talk about phosphorus, foods that are high in phosphorus include chicken, turkey, organ meats, pork, seafood, dairy, sunflower and pumpkin seeds, whole grains, beans, and soy. So dehydration is defined as a clinical combination of extracellular volume deficit and hypernatremia. So basically, there's not enough fluid volume in the vascular and interstitial fluid compartments. So some of the questions that we may ask the client would be, do you work or exercise in a hot environment? About how many glasses of fluid do you usually drink every day? How much alcohol do you drink in a typical week? Because alcohol can dehydrate you. Have you had any recent vomiting or diarrhea? Which medications or herbal supplements do you use regularly? Do you get lightheaded when you stand up? As we look at the physical cues, have they had a weight loss of 2.2 pounds or 1 kilogram or more in a 24-hour period? What's their blood pressure? Are they hypotensive, Do they have orthostatic hypotension symptoms? Do they have lightheadedness when they sit upright or stand up? Is their pulse rapid and thready? Do they have flat or collapsing neck veins when they inhale when they're supine? Do they have sluggish cap refill? How much urine are they putting out and what does it look like? Is it a small amount, dark color? Do they have dry mucous membranes, especially between the cheek and the gums? When we do skin turgor checks, does it fail to return to normal within 3 seconds? Remember, we check skin turgor, not on the back of the hand. The best places, not the only places, but the best places to check: the forehead, the clavicle, or the sternum. We don't check on the back of the hand because as we age or if we have skin damage, that skin can actually stay tinted and not be a true reflection of their hydration. Do they have thirst present with severe hyponatremia? Do they experience restlessness or mild confusion or another sign of decreased level of consciousness, such as lethargy, confusion, or coma? Do they have imbalances of their sodium, calcium, or acid bases? So goals of treatment with the dehydrated client or fluid volume deficit would be the client will be alert and oriented within 24 hours. Electrolytes will be within normal limits within 24 hours. Intake will be within 100 mLs of output within 24 hours. The client will not fall during the rest of the hospital stay. The client will verbalize the need to drink at least 8 glasses of water in 24 hours. Possible hypotheses or client problems with dehydration include acute confusion, risk for electrolyte imbalance, deficient fluid volume, risk for injury, deficient knowledge, and the populations that are most at risk: infants, children, and older adults, with the emphasis being on the very old and the very young. Interventions include assessing vital signs and orientation every shift as needed or as ordered, measuring intake and output, encouraging the client to drink fluids, keeping a water pitcher at the client's bedside, administration of IV therapy if ordered, daily weights, especially if the client is severely dehydrated, instructing the client to call for assistance getting out of bed if they are lightheaded, and teaching the client about ways to prevent dehydration, including that need to drink at least 8 glasses of water every day. And fluid volume overload. This is defined as too much isotonic fluid in the extracellular compartment. It also involves the intake of sodium-containing isotonic fluid that may have exceeded the fluid output. With our assessment, some of the questions we may ask: tell me what you usually eat in a day. Are you on a special diet due to a medical problem? Do you take diuretics or medications for high blood pressure? Are you experiencing swelling of your fingers, feet, or ankles? If you look at the picture here, this is an edema chart, and it shows you the different levels of pitting edema. The physical assessment cues, we may see a weight gain of 2.2 pounds or 1 kilogram or more in a 24-hour period of time. The bounding pulse. Neck veins that are full or distended when the client is upright or semi-upright. We hear crackles or rhonchi in the lungs, and the client has progressive dyspnea, typical sign of fluid volume overload. Crackles or rhonchi in the lungs with progressive dyspnea. We may also see edema present in dependent areas. This is going to be the areas that are lowest on the body. So if they're sitting, it's going to be the feet and ankles. Might be their butt, because those are going to be some of the lowest areas. If they're lying down, it could be all of the surfaces that are in contact with the bed. So dependent, think of gravity and where it's pulling the water to. Possible hypotheses or client problems include decreased cardiac output, excessive fluid volume, or deficient knowledge regarding disease management. Goals of treatment. The client's pulse will be 2+ and regular within 24 hours. It will usually, with fluid volume overload, be 3 to 4+. Intake will be within 100 mLs of output within 24 hours. No neck vein distension within 24 hours. Edema is going to decrease. For example, maybe from a 4+ to a 3+ within 24 hours. The client will list 3 foods that are low in sodium within 24 hours. Different interventions include those daily weights. And when we're doing daily weights, the weight needs to be obtained about the same time every day, wearing about the same amount of clothing prior to eating or drinking after they've gone to the bathroom. So, same time of day, same scale, same amount of clothing prior to eating or drinking after they've gone to the bathroom. Vital signs should be taken every shift, as needed or as ordered. Auscultate lung sounds every shift in PRN. Remember, with fluid volume overload, we're listening for those crackles or rhonchi, and we're monitoring for dyspnea. We're obtaining accurate intake and output, restricting fluids if necessary, administering diuretics and or antihypertensive medications as ordered, assessing for neck vein distension every shift, assessing for edema every shift. And remember, when we have edema, we're trying to use gravity to help reduce it. So elevate the extremities that are edematous. And teach the client about foods that are low in sodium.